If I had to choose all over again, I would still choose obstetrics. There's nothing more rewarding than actually being there at the start of life. So I hope that when you come to do your obstetrics attachment, that you can feel some joy. It can be really frightening doing it as a student because things happen very quickly, and you're learning so much on the job, so it can feel a bit overwhelming. What I did want to do today is not to go into masses of detail about every single obstetric emergency you're likely to come across. And the next slide, I just list some of the obstetric emergencies, and I'm happy to share these slides with you as well. So this just goes through sort of some of the more common obstetric emergencies. Now I'm thinking, and for example, Samir, you're going to be working across different hospital settings, but if you think about maternal collapse has been something that you probably will encounter relatively frequently. So the pregnant woman who comes in a collapsed state. Sepsis, again, there's going to be so much learning here you're going to carry across, not just from what we talk about today, but from what you already know. Again, just thinking about first principles, how do we approach this problem? We're going to talk a little bit today about major obstetric hemorrhage, both antepartum hemorrhage and also postpartum hemorrhage. But again, please don't forget your first principles. Please don't forget what you already know, because there are just a few adaptations we make in terms of resuscitation when we're dealing with a pregnant or newly delivered woman, but the principles remain the same. I'm not going to go into amniotic fluid embolism. I've just included it here as one of those rare emergencies, but can be immediately life-threatening. Preeclampsia, eclampsia has been covered, I think, elsewhere, but we'll touch a little bit on eclampsia. I'm not going to go into thromboembolic or thromboembolic events because, again, PEs, the treatment of a pulmonary embolism in pregnancy is exactly the same as outside of pregnancy. And we're not going to go into cardiac disease so much either. We will talk a little bit with shoulder structure because, again, in terms of the stuff that can happen in delivery suite, this is an emergency, and we all should be aware of first principles on this one as well. So again, if I'm speaking too fast or you don't understand my accent, please just, raise a hand. I can't see your hand, but Behesta, if you can just let me know, then I'll slow down.
Yeah.
Okay, so let's think about first principles then. So the key principles to take away from this, and the key principles when it comes to any form of resuscitation or collapse, as it were, is first of all early recognition of the problem. And I'm going to keep coming back to this as we go through the different scenarios. And the other thing I would say is it's about escalation. You're going to be encountering things as medical students with, your gloves on, getting stuck into different scenarios and situations in real life. But even when you qualify and you're a more junior doctor working within a hospital setting or a community setting, it is absolutely reasonable to call for help. The moment you think that something is going wrong and you know that one pair of hands, one brain is simply not enough, escalate, because that can be the life-saving part of your role in that emergency. Again, just think of first principles. I use the TRIM acronym. So TRIM standing for the T for teamwork, R for resuscitation, I for investigations and monitoring, and M for the measures to arrest the problem. Now, if we think about resuscitation, again, one of the key principles here is if you have a collapsed mother, if you have a very sick mother, you must resuscitate her first before the baby. Because if you fail to resuscitate her and you get task focused on a heart rate of a baby that's perhaps become a decelerative or bradycardic, you cannot resuscitate that baby without resuscitating the mother first. So the principles here are mum before baby, and A before B before C before D before E. Okay. So, and before we leave this slide, the final key principle I would say, it's difficult, and again, I'm just mindful of colleagues in Gaza, that it's difficult when you have multiple major traumas coming in at once to sort of pause to debrief the patient, partner, and staff. But when I'm teaching obstetric emergencies in a sort of setting where there isn't the same intensity, I would always say it's super important to debrief the patient afterwards, to talk to the partner, and also to look after each other and debrief with the staff around. So when we think about key principles, I mean, in honesty, what I should have done is covered this slide to start with and allow you to tell me things, but I'm aware that we're just getting to know each other here a little bit, and interaction can sometimes be difficult, but also internet connections may not be stable. But A before B before C before D before E. There is no point in putting in large bore cannula and drawing blood tests and cross-matching blood, which is your C, if the person has an obstructed airway or cannot ventilate or self-ventilate. So it's absolutely crucial that whatever emergency you approach, that you approach it in this methodical, systematic way, and it's no different whether the patient is pregnant or non-pregnant. So again, fall back on first principles, and we'll come back to this repeatedly as we go through the talk today. And I should say, when it comes to the disability, it says monitor patient's Glasgow coma score. That's important. Under D, I would also say check blood glucose, because hypoglycemia, or in the context of someone with type 1 diabetes, hyperglycemia and DKA can be a cause of collapse too. So I think you should have had the cases to have a little look through. Now I've put these are actual real life cases, as it were. I've just changed some of the names and scenarios, and I've pitched quite a number of these cases in the context of you being the first responder in an emergency department, which is what ED stands for. Okay. So we're going to start with Rosa, who's 32 weeks pregnant. She presents to the emergency room as a result of a multiple vehicle collision. She was the restrained driver of a vehicle that was hit from behind at high speed. And the ambulance has brought her to the emergency room. She's complaining of severe abdominal pain, low back pain, and some vaginal bleeding that started while she was in the ambulance. Okay. So I'm going to stop sharing a moment just so I can see some faces. So can we get a sense then, if this is a patient that came into the ED, what would be your approach to this patient? What problems might she be experiencing that are leading to severe abdominal pain? Any thoughts?
She might be experiencing preterm labor. She might have an internal bleeding, get in shock. She might have uterine rupture.
Yeah, yeah. So that
Um,
80 kilometers per hour is a pretty high speed accident. So you're absolutely right. A pregnant patient,
she could
sorry, go ahead. Someone else is saying.
she could have a placental abruption.
That's absolutely right. So you can think of the pregnancy-related causes and the non-pregnancy-related causes. So you're absolutely right. An RTA or any sort of major trauma in a pregnant patient, you can have intra-abdominal bleeding, which can be concealed. So it could be something to do with a splenic rupture, hepatic laceration, and remembering, just if you think about the position of that seat belt as well. And then we can move to pregnancy-related causes, so preterm labor, uterine rupture, placental abruption. Excellent. So what would be your approach here? So she arrives, she's on a gurney, she's been transferred to a trolley. What is your approach then? It's safe to approach the patient in the context of ED. So what have we just been talking about?
We would do the primary survey, the ABCs. We would
Brilliant.
secure the airway, supplement her with oxygen.
Mm-hmm.
Of course, after checking any trauma to the chest,
Yeah.
there is chest injuries.
Mm-hmm.
We would give her IV fluids
Yeah. So
for
you've
fluid
done your
resuscitation,
A, B, and you're doing your C, which is great. So your IV fluids,
circulation. A,
circulation,
airway, B, breathing, C, circulation.
brilliant.
We would secure two large, secure an IV line for
Mm-hmm.
fluids.
Great.
We would take care about her position to avoid um, any injury to the spine and
Great.
any supine hypotension also. The left tilt, we do the left lateral tilt
Mhm.
and we monitor for shock. We assess the Glasgow, also the Glasgow coma scale. We do a full examination
Great.
to
So
the
the
woman.
that is absolutely fantastic. So we've done the A, B, C, D, E, and then the next letter is F. So how might we monitor the F? F being fetus.
By the
We would
Yeah,
continuous fetal monitoring
yeah. So you
and
pop
bedside ultrasound.
Great. So you can do a better alternative to one, establish you've got a live fetus there. And the second, we apply monitoring. So in that, and I think that's quite a good way of thinking mother before baby, is the A, B, C, D, E, F. Your F is your fetus. So in this slide, we have abruption. So what Rosa actually had was an abruption from the contre-coup action of the sudden acceleration and the deceleration and the impact of the seatbelt across her lower abdomen. So an abruption can be concealed, which is what you have on the right-hand side of the screen here, where you have a bleed behind the placenta, but it hasn't actually come out yet as blood loss, or you can have revealed. And the key important thing is that the degree of shock that a woman can be in can be greater than the revealed blood loss. You're absolutely right to think of intra-abdominal and intrauterine bleeding. So we've talked about the definition of placental abruption is when you have that separation of the placenta either in its entirety or partial from the uterine wall. In terms of risk factors, any risk factors, so here we've got trauma, any other risk factors for placental abruption? What might be more common in the context of obstetrics?
I think hypertension is one
Absolutely,
of the most
yeah.
common.
So if you think about hypertension, either pre-existing hypertension or hypertension that develops during pregnancy, such as preeclampsia, think of particularly preeclampsia and growth restriction as being sort of a product or a sequelae of fundamental placental dysfunction. And wherever you have placental dysfunction, you will have an increased risk of placental abruption, okay? Other risk factors would include smoking. It would include drug misuse, and we sort of sometimes think of drugs such as cocaine or crack cocaine as being a risk factor for sudden vaso-occlusion within the placenta. And then the other risk factor would be choriamnitis. So where we have someone with prolonged rupture of membranes who has a risk of choriamnitis, sometimes it may present as a placental abruption. So you may get bleeding and continuous pain. But it's important just, again, to consider the primary survey and the primary management. Okay, so we've got the general management, and thank you for the A, B, C, D, E, F. And then the specific would be, can we arrest the bleeding? So in the context of placental abruption, we cannot arrest the bleeding. If the bleeding was significant to cause maternal or fetal compromise or both, despite adequate resuscitation of the mother, it may become necessary to deliver that baby. And the mode of birth and how we do that would depend on the degree of compromise of mother and or baby. What might be the complications of abruption for the mother? So say she's had sort of very severe hypotension and she's had large volume blood loss. What might be the complications for mother?
Hypovolemic shock.
So hypovolemic shock. The other thing to bear in mind is when you have, particularly in the context of abruption, you can get the release into maternal circulation, various sort of coagulopathic thromboplastins from that placental separation, and that can lead to DIC. Equally, you can get DIC from the massive blood volume loss. Just coincidentally, before I came onto this call, one of the roles I have in my organization is maternity safety, and I was just reviewing the case of a young mother who sadly had a 28-week massive placental abruption. Her baby sadly died, but very early in that presentation of her massive placental abruption, she had severe DIC. So in terms of trying to manage her and manage her birth and her labor and her birth, it was actually correction of the coagulopathy as well as the correction of her anemia. I should say with that particular mother, her presentation was of a concealed hemorrhage, and what she did have when we examined her abdomen was a very tense, tender uterus. And we often refer to that as sort of a woody uterus. It feels rock hard, and it's extremely painful. So the other thing to bear in mind is wherever we have a woman in pain, wherever possible, please give some pain relief as well. Now, for a baby that has experienced a placental abruption, there is that risk of hypoxic brain injury, as well as a risk of anemia within the baby, because you have this sudden separation and you can get blood loss from the baby's compartment back into that placental circulation as well. So if we move then to Anna. So we're going to shift gear a little bit, but again, thinking of the same first principles. So in this case, Anna is a grand multip by UK standard. She's a para 4, and she attends the emergency room in labour and very rapidly gives birth to a fairly large baby at 4.5 kilograms. Baby is born in good condition, and the placenta is born shortly afterwards by controlled cord traction. The team are making plans to move the woman to the postnatal ward, but they notice that on transfer from the bed to the chair to move her into the ward, there's a sudden gush of blood vaginally. And very rapidly, she loses an estimated loss of about 1,700 mils, and she's continuing to bleed. So again, I'm going to roll it out to you guys. What will be your next step? So she's still in the emergency room at this point. Oh, great. I'm just looking. We've had more people join. So let's hear from the others around the room. What will be your approach to this woman? So first of all, are you going to continue to transfer her to a postnatal ward, or are you going to pop her back on the bed? Again, feel free to unmute yourselves and just shout out some answers at me. Make me feel loved. And there's no wrong answers. So please, if you had a patient who was hemorrhaging before you, forget about the fact she's just had a baby, what would you do next? Absolutely. So you'd call your obstetric emergency. So we've got early recognition that she's hemorrhaging, and we're going to escalate. So you'd call and you'd ask for the most senior team that you can, because this woman could well exsanguinate if she's not managed appropriately. So we've already talked about the A, B, C, D. Does she have an A problem? No. On this occasion, Anna is able to tell you that she doesn't feel very well. So she's perfusing, she's not got an obstructed airway because she's speaking to you. She's able to articulate, speak, therefore she can ventilate, she can breathe, and she can self-ventilate. But even in the context of that, with someone who's hemorrhaging, they may rapidly lose their oxygen carrying capacity in the form of red blood cells. So you would apply your oxygen mask with a non-rebreathable mask, and you'd certainly open up the oxygen inlet to about 50 meters per minute. We've got a circulation problem here, haven't we? So what you would consider then is getting your large bore cannula. So very similar to the principles we've just discussed, large bore cannula going in, 2 if you can, and then to quickly, sorry, I've just realized I have now not, can you see the slide that says Anna? Yeah?
Yep.
Brilliant. So you're going to put your IV cannula in, you're going to get your bloods off, including a cross match for 4 units if possible. You're going to check her clotting at baseline because she's lost a significant amount of blood volume in one go. And you're going to apply your relevant monitoring. So that's the other thing is as you go through your A, B, C, D, you assess and then you establish your monitoring. So a pulse oximeter to go on to assess oxygen saturation. So that will help your A and your B. And your C, you're going to assess blood pressure and pulse. And don't forget end organ as well. So in this case, the kidneys are end organ. And if she's continued to hemorrhage, you'd certainly consider catheter to assess renal perfusion and also to help you with your fluid balance and know how much you need to give in order to sustain some form of intravascular volume. And if necessary, you can give blood at that point. Okay, so that's the general things. And now the reason why I'm sort of talking postpartum hemorrhage here is just also to say that in your specialist or non-specialist future careers, you may well encounter this because it's one of the leading causes of morbidity in pregnant women worldwide. So we've gone straight in here to talk about management. I'm going to sort of pull us back a little bit and then think about definitions. Now, the definition in your textbooks will typically say that a postpartum hemorrhage is a blood loss of 500 mils or more in a woman who delivers vaginally, and about 1,000 mils or more in a woman who's a surgical birth, such as cesarean section. I'm going to encourage you to think a bit wider than that, because if we've got someone with a low BMI, so when I was in Gaza, I didn't encounter many obese women, and what I encountered was women who had a low BMI and also with a high prevalence of baseline anemia. So in that context, losing 500 mils of blood may constitute a major hemorrhage because it's very likely a person who's already anemic with low BMI is going to decompensate before they get to 500 mils. So please bear that in mind. So I would say that a better definition is a volume of blood loss that is sufficient to cause some degree of hemodynamic instability. Now, with that, please bear in mind that in pregnancy, there is a 40% increase in plasma volume. And there is also changes in the cardiovascular system. And the third thing is that most women are younger and generally fit, and therefore will tolerate up to 1/3 of their blood loss before they become tachycardic or hypotensive. So do not wait until someone is hypotensive or tachycardic in the presence of bleeding before you start to intervene, okay? So if we think of types of postpartum hemorrhage, we sort of call it primary postpartum hemorrhage, which was bleeding within the first 24 hours of birth, and secondary postpartum hemorrhage, which is bleeding thereafter, usually within the first 6 weeks, but more commonly within the first 10 days. And postpartum hemorrhage that is secondary is quite often due to intrauterine infection or to do with retained tissue, whether that is placental tissue or clot that has become organized and then infected. And the management will be slightly different. So if we think specifically to Anna, and I really will encourage you to please unmute and shout out some answers at me. But if we think about Anna, can you think of, she's a power of 4, she's had a 4.5 kilogram baby, she's come into the emergency room and very rapidly delivered a baby. The placenta has delivered, but what are her risk factors here for primary postpartum hemorrhage? Any thoughts on that? And I can't see the screen, so please just unmute and shout out some answers.
And maybe uterine atony?
Absolutely. So in the presence of uterine atony is one of the 4 T's. So we've got in the 4 T's, we've got tone, we've got tone, we've got trauma, a tear, we've got tissue. So for example, retained products, retained placental cotyledons. And the 4th, which is less common, is thrombogenesis. Yeah. So if, for example, we had Rosa experiencing a postpartum hemorrhage, we might be more likely to think of something like a DIC scenario. But in this situation, we've got specific risk factors for an atony issue. We've got a large baby, so it's a degree of over-distension of the uterus. We've got a rapid progress in labor. So again, sometimes the uterus just doesn't stay contracted after birth. And those large sort of myometrial and radial vessels that come through the muscle of the uterus, if the uterus is not contracted down that, you don't get that same level of, as it were, like a tourniquet around those vessels. So that will direct the immediate course of action. But also remember, if it's happened before, it can happen again. So if a woman has a previous hemorrhage in a previous pregnancy, she's at a higher risk of it happening again compared to someone who's never experienced hemorrhage. Grand multiparity. So the more babies a person has, the greater that risk of hemorrhage as well. So when it comes to management, we've already discussed some of the immediate management, which is going to be no different from any other patient who's hemorrhaging, the A, B, C, D, E. We can think of some specific things, the things that you could do in that emergency room before your obstetricians come along, and that's uterine massage. Now, the images that I've shown here are sort of two slightly more extremes. One is the one on the left is the bimanual, where you literally would insert a hand into the vagina, pressing upwards, and then with your abdominal hand pressed downwards, you're physically compressing that space. And that can help if you've got an uterine atony as the primary cause of your bleeding. But sometimes just simply rubbing up the uterus that you feel through the abdomen is sufficient to stimulate a contraction to help keep that uterus contracted. We can give uterotonic medications. I'm going to come to that in the next slide. But importantly, getting IV access established, getting some crystalloid fluid going in is super important to maintain intravascular volume. And then one might consider some blood and clotting products. If a woman continued to bleed, so you're part of that sort of the E is that exposure. So you're actually looking at the perineum, you're assessing for trauma. If you had a situation of ongoing bleeding in the absence of major sort of perineal trauma, it may be worth, in fact, it could be life-saving to bring that patient to theatre, to examine her under general anaesthetic, to assess the cavity of the uterus for any retained products. And that would also enable a balloon tamponade. So something like the Bakri balloon or the Zenstack tube that you might use in context of esophageal bleeding. It can be used in a context of intrauterine blood loss, where you simply insert the catheter tubes through the cervix into the cavity of the uterus and inflate, 50, 100, 200 mils as you need to. But I have put down here in extremis hysterectomy. It is very important that if a woman is in front of you and you've exhausted your primary and secondary measures, so you've done all the mechanical things, you've given the maximum amount of uterotonic medication, or you do not have access to that medication, or you do not have access to blood products in the context of a resource-constrained service, it may be that a hysterectomy must be considered in order to save her life. And that is not undertaken lightly, particularly in someone who's perhaps having their first child, but it can be life-saving. So in relation to medications, obstetrics is not difficult. There are not many medications that one has to know, in contrast to things like cardiology and respiratory medicine. So we've got very few drugs and the actions tend to be fairly similar. So in the context of postpartum hemorrhage, we would consider oxytocin and ergometrin in a combined form known as syntocinon. And this acts in two different ways. It can act on the oxytocin receptors within the uterus to stimulate that contraction. It can also, the ergometrin element of syntometrin can also lead to vasoconstriction. So in this table, we have syntocinon and ergometrin separately. It may be where you work or see practice that they have the combined product known as syntometrin. Carbaprost is a prostaglandin F2 alpha analog, and it is used either intramyometrally or intramuscularly, and it will induce a rapid uterine contraction. It must not be given intravenously because you can get vascular necrosis so it can actually act on the blood vessels to lead to damage there. And again, with ergometrin and carbaprost, you certainly consider some caution if you know the patient has hypertension, preeclampsia, or underlying severe asthma. So those would be considered relative contraindications. Misoprostol is one of those drugs that should be widely available. It's, in the context of obstetrics, it's an incredibly useful drug. It's a prostaglandin E analog, and it acts again as a uterotonic. It can be given vaginally or rectally, and actually it can be given orally as well. Just this onset of action will be slower if it's given orally. There's one drug that's missing off this slide. Can anyone tell me what drug is not there? So a drug that may be used in the context of trauma or surgical trauma where you have excess bleeding. So nothing to do with obstetrics, but what drug is not on?
The hexacapran.
Say that
The
again?
hexacapran. Hexacapran or the
Yes, so I know it's a slightly different name. We know
yeah,
it's yeah.
yeah, it's the tranexamic acid. We here call it hexacapran.
Hexacap. So this is one of those drugs that in large studies, it's now shown that this is the one drug that actually reduces the risk of maternal death and also reduces the risk of hysterectomy and life-threatening postpartum hemorrhage. So, I mean, it's a crucial drug. Early in that sort of postpartum hemorrhage, you can get TPA and other elements of the coagulation cascade that will actually cause fibrin, which can be, the things that help plug those vessels to break down. So tranexamic acid works by inhibiting fibrinolysis. It is safe, it is effective, it is heat stable. So like misoprostol, it does not need to be stored in a fridge. It is given intravenously in a hemorrhage situation, and it is given early in the hemorrhage. So it is important that our protocols now in the UK would say that where you have a woman who is hemodynamically unstable because of hemorrhage, or there's blood loss greater than 500 in the context of vaginal birth, or more than a litre in the context of cesarean section, we would standardly give 1 gram of tranexamic acid and also then give the uterotonics after that. And it does lead to less blood products being transfused. Okay, I'm going to just pause for a sip of water. Are there any questions based on the hemorrhage scenarios? Again, I can't see the screen with my presentation on, so if you have got your hand up, just please unmute yourself and just ask the question. Okay, if not, I'm just going to summarize this by saying hemorrhage is hemorrhage. You already have the skills and the knowledge to manage hemorrhage. All that I've added here is some additional sort of first principles, namely that the F comes after the maternal A, B, C, D, E. Think of the fetal placental unit that has been monitored with that F in the way of monitoring the fetal heart. Think of that fetal placental unit as an end organ of the woman. So where you have distress evident on a CTG, that is an end organ dysfunction. Continue to resuscitate your mother as best possible before you start to deliver the baby. If you try and deliver a baby without resuscitating the mother adequately, you will run the risk of losing 2 lives rather than just 1. Okay. And I can tell you from experience, both here and working overseas, that the majority of women who come in bleeding or in a state of a degree of collapse, their primary interest is to save the baby, not themselves. You must be the professional and the doctor here and remember the A, B, C, D, E, F. Okay, I'm going to take us away from hemorrhage into another scenario that you may encounter. And I'm mindful that with the disruption of healthcare, particularly in Gaza, but also to a degree within the West Bank, you may have women who are not accessing their maternity care as well as they should do. They may not be accessing care and therefore may not have a diagnosis of preeclampsia or a management of severe hypertension. So I just want to take us through this particular scenario where you've got a woman who presents to your emergency room. The ambulance is called in en route to the hospital to say that she's in the ambulance having a generalized tonic-clonic seizure, that the ambulance was initially called because of severe headache and blurred vision. The partner reports that the woman also appeared to be becoming confused. And when the ambulance arrived, she was initially conscious on the scene before having the fit. They were able to measure her blood pressure as 190/88. Now, it is an obstetric emergencies lecture, so can anyone hazard a guess as to what the diagnosis here is?
Eclampsia.
Eclampsia. So it's most likely an eclamptic fit. We do from time to time encounter women who have epilepsy, and this could also be the situation of women with epilepsy, uncontrolled, having a seizure in pregnancy. But the hypertension here is severe. The other scenario can be, and this is occasional, but it does happen, is if she's had an intracranial bleed for some other reason, and this has led to a seizure. But in this scenario, it is an eclamptic seizure. Okay, so what preparations might you make for her arrival? You've got 3 minutes to assemble a team and assemble things that might be life-saving in the first 5 minutes of her arrival. So what preparations are you going to make? Remember, she's still pregnant at this point. I feel you're all being very shy. I have taught in Gaza, and I've always been incredibly impressed with how much more astute the Palestinian medical students are than some of the ones I teach in Oxford. So I'm going to reckon this is that you're feeling shy. So the preparations, I like to think in acronyms. So the acronym I'd use for preparations would be SOAPs. You want the most senior, your S, obstetrician, anesthetist, pediatrician present for this woman, okay? You also would like someone to scribe, so you can actually start having someone, could be any member of the team, to scribe, to write down the observations, what medication's given, when it's given, what the actions are. You also want your emergency box, and it may be that where you see practice or where you work, there's an eclampsia emergency box, but you'd certainly want to assemble medication and have it ready. One might consider as well, for any person having a seizure, forget about the pregnancy. If we're thinking about the ABC, what might be the issues in particular for someone who's having a seizure in relation to A, B, and C? Does anyone want to pop a hand up or show me some love and shout out an answer? Okay, I'm going to put it down to shyness. So we want to think about the fact that if she is unconscious, that her airway may be compromised. So we want to ensure that we position her properly, that we consider, if necessary, in a deeply unconscious or post-ictal patient, we consider whether we need to do jaw thrust or head tilt, chin lift, okay? If her airway cannot be maintained, we want to be discussing with her anaesthetist the correct actions. So, if we then think about an eclamptic seizure on its own, the majority, in fact, I've not yet encountered a situation of an eclamptic seizure that isn't self-limiting. So the key thing is positioning that patient. And if she's pregnant, you'd also want to consider manual uterine displacement to prevent venocable compression, or tilt the patient or roll her to her recovery position, but maintaining that airway. We're going to use the ABCD approach as before. The F comes at the end. So as part of the C and the F, you would consider your continuous blood pressure monitoring, as well as your saturations, as well as applying some monitoring to the baby. But we're not going to act on the fetal heart rate tracing until we have stabilized mother. And crucially here, the stabilization is controlling the blood pressure. Uncontrolled severe hypertension risks a woman having a major intracranial hemorrhage. And still in the UK, every year when we review our confidential inquiry into maternal deaths across the UK, we will have a woman who experiences severe morbidity or death because of a stroke due to uncontrolled hypertension. So a seizure will rarely kill a patient, but severe hypertension will, or lead to morbidity. So we can do that either IV labetalol, if the patient's unconscious. If there's any contraindications to labetalol, we might consider something like IV hydralazine. If the patient is conscious, we could seek to control severe hypertension with nifedipine orally. But in an emergency situation, more often than not, it is through IV labetalol. To prevent further seizures, we can administer IV magnesium sulfate, and I've put the doses there. But in honesty, as medical students, I think the key thing to remember is we give mag sulf, and we can give it as a loading dose, a large loading dose of 4 grams, and then we would maintain a lower dose infusion over the following 24 hours. And when we have stabilized the mother, we would then consider delivery of the baby. It would be a very rare situation where a woman has an eclamptic seizure that we do not consider delivery of the baby, because her severe preeclampsia is not going to improve until the baby and the placenta are delivered. Okay. Now, are there any questions on what we've discussed on that? Again, I can't see the screen and your name. So if you have any questions, please unmute and ask. Okay, but so I'll sort of close off on the eclampsia to say that it is fairly uncommon. I suspect in situations with disrupted healthcare that you will see more eclampsia than you would do with a non-disrupted healthcare system, where access to care can be challenged in the disrupted healthcare system. Remembering the basic principles is important. Remembering that they may have preceding headache, confusion, but it may present as another form of complications of preeclampsia. For example, we sometimes encounter eclamptic seizures with women with HELLP syndrome. Remember, the seizure, although it's distressing to see, it is usually self-limiting. We still can stabilize by basic airway, breathing, and circulation support. And then thinking about the need to stabilize the mother before we consider delivery of the baby. And for the mother, there are risks we've discussed of intracranial hemorrhage, but also other end organ damage, as well as the potential for pulmonary edema. So it's very important to control fluid balance in this situation. And obviously for the baby, some of the complications would include fetal distress, abruptions more common in preeclampsia, eclampsia, and preterm birth, which would be iatrogenic. In practice, I'm not going to go into today because of time, but do consider the potential signs of magnesium toxicity. Magnesium is not a pleasant drug for a woman to receive, but some of the signs of toxicity can be absent reflexes. So that is why we need to keep a close eye on neurological status after we give magnesium. It is excreted by the kidneys. So where you have a kidney insult or acute kidney injury as a result of the eclampsia, severe preeclampsia, we need to monitor urine output very closely. And we need to consider reversing the effects of magnesium if there's any evidence of magnesium toxicity, and that would be through calcium glucagon. Okay. So I've changed up the color of my slides at the sort of 40-minute mark just to reinvigorate us all.
Oh,
So,
Dr. Kelly, I don't think we can see the slides.
at all.
We have been, but I think right now when you said you've changed the color of the slides, I can't see any of the slides. I don't know if anyone else can.
So can you see a blue slide?
Oh, I can't see any slide.
No. Oh my goodness. Okay. That's and if I change the slide again to here, can you see a table?
No, I think it's just acting as if you're not sharing anything right now.
Okay, so let me escape and share. So what can you see now?
Oh, perfect. So we can see this slide like on PowerPoint, blue background, there's a table. We can see, yeah, that's perfect. We can see it.
Okay. Okay. So this is moved into a slightly more specialist area. And again, I'm going to try and get us to think from first principles. So with this woman, we've now got a woman who's had 3 babies. She's 32 weeks pregnant. She had 2 normal births followed by cesarean section. So she has a scar on her uterus. She's very keen for a vaginal birth. And we've got some basic sort of findings there. Hemoglobin's 98. She's got a low BMI of 18. How would you counsel her? So again, I'm aware that interaction over Zoom isn't so easy, but the key consideration here is in relation to the fact she's got a scar on her uterus. And certainly we would consider supporting in her birth choice towards vaginal delivery, particularly if she's planning for the children. But the key thing is this risk of the scar rupture, which is about 1 in 200. So she's very likely to deliver vaginally safely, and that will be better for her recovery afterwards, better for the baby in relation to less risk of neonatal respiratory morbidity in the form of TTN, but it doesn't come without risks of uterine rupture. So fast forward 6 weeks, she presents to the labor ward. She's 38 weeks pregnant. She's contracting, so she's in established labor. Midwife's examined her. She's 4 centimeters dilated. Her observations are fine. And we have this as a CTG reading. Now, I'm not sure if you've come across CTGs before or not. Can I get a sense of if you have? A few of you seen practice, but what we have here in the top is the heart rate trace of the baby. And what we have here in the bottom is what we call the tachograph, which is a measure of the contractions. And so this is a normal baseline reading of the baby. The wiggliness around the line is called the variability, and that is normal. It's between 5 and 15 beats per minute. And these little peaks that we see are a very healthy sign of a neurologically intact baby that's perfusing its brain well. These are accelerations, and these are considered a very healthy sign. So in this situation, there's no hypoxia. 4 hours later, the midwife examines her, and what we have here is a situation of an acute fetal bradycardia. So what do you think is happening in this situation? So we've talked.
I'm afraid that the uterus has ruptured.
Yeah, so that is a key concern. The woman at this point is complaining of severe constant lower abdominal pain. So that might be an indication of uterine rupture, but also it might be an indication of a placental abruption, which could also lead to an acute profound hypoxic situation for the baby. The contractions have stopped, so that sometimes is the heralding sign of a uterine rupture, where a woman who has been contracting previously, the contractions just stop. There can be scar tenderness, but that can be difficult to dissociate between just general uterine tenderness. You may or may not have vaginal bleeding, but notably in this situation, we've got a multiparous woman who 4 hours after contractions is still only 4 centimeters. So this may have been in the context of a uterine sort of obstructed labor, which would increase the risk of a uterine rupture. And the head, which previously was at the spines, is now higher. So the baby has almost like moved up into the uterus. And these can be the sort of textbook signs of a uterine rupture. It is actually one of those very frightening situations as an obstetrician, because you're doing your ABC with the emphasis that this is a C problem. And you're rapidly getting that woman to theatre once you've established your venous access, you've started intravascular resuscitation, you've ordered your blood products. And such have been uterine ruptures in my clinical experience. I've sometimes fished babies out from underneath the liver where you've had a complete uterine rupture. And so it can, really sort of cause quite severe disability for the baby or death, and also significant morbidity for the woman in terms of major hemorrhage as well. The final scenario, and this is just to bring you through first principles, I just want us to think about in terms of labor ward scenarios. So the uterine rupture being one, is shoulder dystocia. And again, this is just in case you happen to be, I'm not imagining that you're all going to be obstetricians, but you may encounter a woman who delivers in the emergency room where the head delivers, but the shoulders do not. And this is an obstetric emergency because the baby can rapidly become hypoxic. You probably have, for a term, normally grown baby, you probably have at most 7 minutes to deliver that baby before there is irreversible hypoxic brain injury. And that is the sort of the impact on the perfusion, the cord can become very compressed in that situation. and you can have a sudden drop in the oxygenation of the baby. The key thing, and unfortunately my pointer doesn't work on this slide, but the key thing around shoulder dystocia is it's a mechanical obstruction. So if you think about a baby coming through the bony pelvis, the baby has to navigate head and shoulders through a tunnel where the entrance to the tunnel is a different shape from the exit. So the baby has to undergo a rotation. If the shoulders are not able to undergo that rotation, they can get impacted in the uterus at that point, just behind the pubic bone. So all subsequent maneuvers to deliver that baby to try and release that anterior shoulder from underneath that pubic bone. And so it isn't something that's really common, but it is something that is more common if the baby is 4 kilograms or above. Having said that, 50% of shoulder dystocias will happen in babies of normal birth weight. Another risk factor for this would be maternal diabetes, where you can have a baby with that's larger than expected. But in 50% of cases, there are no discernible risk factors, so it can happen unexpectedly. Some clinical suspicion should arise if the labor progress slows down, particularly in the second stage. And so when I'm teaching my trainees, I always say that when we're preparing to do an instrumental birth, we should also be mentally preparing as we wash our hands for how we would manage a shoulder dystocia. And so, as I say, the key thing here is remembering it's about relieving the mechanical obstruction. And so that can be as simple as knowing that if we can hyperflex the maternal legs, so bend her knees, hyperflex those thighs towards her abdomen, and then externally, so abduct those thighs, externally rotate and abduct the thighs, and that will increase the space within the sacral area. And that can be sufficient, just that movement can be sufficient to rock the shoulders from underneath, and now you've created a bit more functional space. The second mechanical maneuver would be just to identify which side the baby's back is on, and then to apply your hands as though you're doing CPR and chest compressions. So interlocking your hands and simply applying the heel with straight arms, applying the heel against the above the suprapubic bone in the direction the baby is facing. So away from the baby's back, pushing, physically pushing that. And that is much easier if the woman is of a normal BMI. It is harder if the woman is obese. But between that first and second movement, you will release about 80% of shoulder dystocias. Thereafter, we're now looking at internal maneuvers. And this can be extremely traumatic for women because quite literally what you will have to do is insert the whole of one's hand into the vagina. And sometimes that may mean that an episiotomy is necessary in order to enable space for the hand to go in. Remember, there's no space really between the baby's upper ear and the pubic bone. So it's very difficult to go in from the top. So we usually go into the sacral area, and that's why you got this sort of, we talk about the pincer grip. So in the photograph here, you have the person demonstrating a bracelet in their hand. So imagine you pull the bracelet down over your hand, you're trying to get it off. You put a pincer grip in, you put your whole hand in, and then you can either reach to the posterior shoulder and just rotate it and bring that arm out, and that will automatically rotate the baby. Or physically, you'll put your hand up along the back of the baby's back to the anterior shoulder and push it forward. And I would say that the majority of shoulder dystocias I've been involved with, including the most difficult, releasing that posterior arm has been sufficient to secure delivery. Now, obviously, if you have a situation where, again, think of complications for mother and baby, if you have a situation where you've had to do such maneuvers, there will be a risk with shoulder dystocia of brachial plexus injury. So it's really important to stay calm and not just pull on the baby's head, because that is not going to release the anterior shoulder at all. It's important that we release that anterior shoulder and gently apply axial traction, or otherwise we will get brachial plexus injury. Humeral fracture clavicle fractures can sometimes happen here as well. But what we're trying to avoid is an hypoxic brain injury for this baby. For mother, apart from the psychological trauma that's happening, there's also a risk of physical trauma, so extended tears, episiotomy, bleeding, and infection, as well as postpartum hemorrhage. So unfortunately, as an obstetrician, your job isn't over once the baby's delivered. You must inspect the mother for any tears and treat any hemorrhage and so forth as necessary. I'm just conscious of time. So what I'm going to do is just allow you to read the next couple of slides. So we have, this is a slide again. I'm going to come back to things where I would like you to think about applying the knowledge you have already, not being overly afraid of obstetrics, remembering that a pregnant woman is still a woman, that there's no third biological gender, it's not male, female, and pregnant person. So treating conditions such as hemorrhage, such as seizures, that the basic first principles are the same. But in this situation, we've got a woman with severe abdominal pain. She has delivered a baby 2 days ago. She had fever and labor, was initially getting better, but then started complaining of severe abdominal pain. Her husband felt she was confused, therefore called an ambulance. The attendant paramedics could not record her blood pressure, it was so low, and she comes into your ED. When she arrives, she's tachycardic, her blood pressure is low, and always, again, a rule of thumb, if the pulse rate is higher than the systolic blood pressure, you have a shock issue. And your key thing here is to think about what the causes of that hypovolemic shock might be. A clue can sometimes be had in the pulse pressure. So a person who is experiencing shock because of hypovolemia due to, for example, blood loss, may have a narrowed pulse pressure, so a low systolic blood pressure, but sufficient vasoconstriction that they have maintained their diastolic blood pressure. The problem with this situation is a wider pulse pressure. That, combined with the temperature of 38, leads us to suspect that this woman may be in septic shock. And a sign is the wider pulse pressure that you can get as you get complete loss of vasoregulation. I'm going to signpost you if you want a good source of information around management of sepsis, and the management is exactly the same whether you're a pregnant patient or a non-pregnant patient. I would recommend that you access the UK Sepsis Trust website. And I've just taken these slides from one of the resources they have for professionals. What we want to try and do when we have a person with severe infection is intervene before we get to the point of sepsis. Once we're in a position of sepsis, unless we introduce the sepsis 6 bundle rapidly, and we talk about the golden hour, getting 6 things done in that first hour, we may rapidly have a person who decompensates into septic shock or severe sepsis. Once we get to septic shock, the mortality is high. It can be as high as 60 to 70%. So it's absolutely crucial to try and intervene quickly. And part of that starts with early recognition. So in this particular woman's case, she was not treated appropriately at home by her GP. She was not examined, and she was in extremis by the time she arrived. And I'm just going to finish. I know that sometimes we can think that in the UK we get most things right. I'm going to come back to our confidential inquiries into maternal deaths. And what we find, this is something that comes out every 3 years, and what we find repeatedly in relation to severe sepsis are a significant number of deaths where, unfortunately, there is substandard care. And again, I'm thinking here that this is something in a disrupted healthcare system that you might see, for example, and sadly at the moment in Gaza, you may see this happening within your ER. So I'm just going to let you read the particular slides here. I've got 2 slides, both real life situations. So crucially with this was a patient who arrived in a collapsed situation, but what was happening was the mental model persisted that this must be hemorrhage because she had a little bit of bleeding. There wasn't really this sort of situational awareness to take into account the whole situation and her background risk, given that she had some evidence of intrapartum infection. So in this situation, it was a group A strep infection. And group A strep is notorious in that it can become rapidly fulminating and die. Even we've seen group A strep deaths, even where we've managed to institute the sepsis bundle within 1 hour. And that reflects the sort of extreme pathogenicity of the group A strep. I will say that group A strep is mainly something that is a woman will self-inoculate with. So for example, if a woman has small children who have group A strep throat infections, they may transmit that to the woman. And sometimes it can happen that it's transmitted from the woman's hands to her genitals. So sometimes that can be the portal of entry. So what we do encourage a woman to do is wash hands before and after they go to the toilet or where they touch genitals in terms of any hygiene care, because of that risk of auto-inoculation. But it is a tragic situation when a woman dies in this scenario. And then the final scenario I'm just going to share with you today is this scenario. Again, it's that desire to prolong pregnancy against better judgment. So here we have a woman who's 22 weeks pregnant with premature rupture of membranes. And wherever we have extreme premature rupture of membranes, we must always think that infection is what's driven those membranes to rupture so early. So in this situation, she was transferred to a tertiary unit within a neonatal intensive care facility. She was counseled about the risk of having a baby prematurely, but the bit that was missing was the risk for her health of severe sepsis should she continue pregnancy. So not only can infection be the reason why the membranes rupture to start with, and that may not be immediately evident on full blood count and CRP, but it is a risk that it can develop in utero, it can lead to the rupture of membranes, but equally, you can also have that portal of infection from the lower genital tract into the upper genital tract. So bugs that are part of the vaginal flora, which do not cause any harm in the lower genital tract and the perineum, if they get into that space around the uterus, that warm, dark space, it can provide the perfect culture for bacteria. And in this case, it was an E. coli bacteria. But in Ireland, about 6 years ago, there was a situation of a woman in a very similar situation where she had ruptured membranes, just less than 20 weeks in pregnancy. And such was the desire to continue the pregnancy. And that was partly driven by the law at the time prohibited abortion. But unfortunately, she died and her baby died anyway. Because of severe sepsis and because of not being managed appropriately. So again, it's just thinking about where our own bias and beliefs and value systems are when we're looking after. The key thing here is, had we expedited delivery, even at 22 weeks, we would have saved a mother, even if we would have lost the baby. So I'm just going to finish, and I'm sorry I've gone slightly over the time. Just coming back to the key principles. Do not forget what you already know. And my experience of teaching Palestinian medical students are you're already extremely well learned and got very, very sound basic knowledge as well. So apply what you know whenever you're facing an obstetric situation of an emergency. Remember your early recognition and escalation. Get help early. Remember the importance of teamwork, the order of your resuscitation, mum before baby, so the fetus comes towards the end of your A, B, C, D, E, F. Remember your investigations and monitoring, very similar to what you do in a non-obstetric situation. The only thing that will differ are the measures. Some of them will be unique to obstetrics. There are very few drugs that you need to know, but just remember that table we've discussed. And if there's time, debrief patient, partner, and staff. I'm going to finish there. Are there any questions?